Hello, everyone. Welcome. We're here to listen to a very interesting topic this afternoon, hereditary neuropathy and genetic testing, presented by the Foundation for Peripheral Neuropathy and kindly sponsored for us by Alnylam Pharmaceutical. I want to introduce myself. My name is Nancy Froman. I'm the Director of Development and Marketing for the Foundation for Peripheral Neuropathy. And here with me are my colleagues as well, Tanya and Lindsay. We will be your hosts for this afternoon. Before we begin, just a couple of housekeeping notes. This presentation will be recorded. We will send you a recording link by email so you can view it later. We'll also have the recording up on our website in the next few days. If you have questions for our experts, we will be addressing as many of them as we can at the end of the session. Please put your questions in the question box. We will see them and we will try to answer them. If we can't get to them during this session, we'll try to get to them at another point in time. And if you're having trouble with the audio, you can dial in by phone. There'll be a number in the email that was sent to you with registration information. I'd like to start off and jump right in and introduce our two speakers who have come to us this afternoon to share their expertise and their knowledge with us. The first is Dr. Brett McCray. Dr. McCray is an assistant professor in neurology at Johns Hopkins. He is a physician scientist with a clinical and research focus on Charcot-Marie tooth, CMT disease, and other forms of peripheral neuropathy. He currently serves as the co-director of the Johns Hopkins CMT Clinic and the Johns Hopkins Site Principal Investigator for the Inherited Neuropathy Consortium Genetics and Natural History CMT study. In addition to caring for patients, he also runs a basic science lab focused on the pathogenesis of inherited forms of peripheral neuropathy. His current work is focused on understanding the pathogenesis of CMT type 2C, and he's establishing a registry for patients that fall into this subset of patients. And after Dr. McCray, we will have Christy Smith joining us, who is a board-certified genetic counselor at Johns Hopkins Department of Genetic Medicine. She sees pediatric and adult patients with a special interest in those with inherited forms of neuromuscular disease, retinal disorders, and pediatric cancers. She received her Master's of Science in Genetic Counseling from Johns Hopkins National Human Genome Research Institute. In addition to her clinical work, she is an active member of the National Society of Genetic Counselors, Maryland, D.C. Society of Genetic Counselors, as well as a member of the American Board of Genetic Counseling, and she teaches in addition to all of those other activities. We thank them for joining us today, and without further ado, I welcome Dr. McCray to start us off on inherited and hereditary neuropathies.
Thanks, Nancy. Thanks for the nice introduction and for the opportunity to speak to this group today. So I'll jump right in since Nancy did such a nice job of introducing me. Control here. There we go. So first, I want to just give you sort of a perspective or neurologist perspective on how we think of peripheral neuropathy. And this may be something many of you know, but hopefully I can give you a little bit of a sense of how we think about neuropathy. So we sort of think of the nervous system in terms of the brain and spinal cord as the central nervous system. And then the things beyond that that leave the spinal cord make up the peripheral nervous system. And so when we talk about peripheral neuropathy, we're really talking about these nerves after they've left the brain and spinal cord and entered into the periphery of the body. So if you have a sensory neuropathy, this is a neuropathy that affects the sensory nerves. This can lead to a number of different symptoms, as many of you may know, can cause numbness or sort of lack of sensation, or can cause extra abnormal sensations, which can range from tingling to pain to other sort of strange or unusual sensations that can be really hard to describe, electrical sensations, pain, cold, etc. And then neuropathies can also affect the motor nerves. And when that happens, they affect strength and can also lead to reduction in the bulk of muscles, what we call muscle atrophy. So peripheral neuropathy in general usually follows a pretty typical pattern. And so one of the main features is that it's usually symmetrical, meaning that it affects both sides of the body equally. So if you have neuropathy in your feet, usually the feet feel about the same, and same in the hands. Usually there's not big differences between either side of the body. And the other thing that we think about a lot is what we call the length-dependent nature of peripheral neuropathy. And so what this refers to is that in most forms of peripheral neuropathy, whether they're inherited or not, they affect the longest nerves first. And those longest nerves go to the feet and toes. And so if you have a length-dependent neuropathy, generally that will start in the toes and feet with symptoms of numbness or weakness. And then over time, if it progresses and gets worse, it then starts to affect nerves that are shorter and kind of moves up the legs. And if it progresses further, gets up to about the knees. And at this point, the nerves that go to the knees are about as long as those that go to the hands. And so with this sort of length-dependent pattern, you can start to get symptoms in the hands as well. So to take a step back, what are these peripheral nerves and how do we think about them? And so basically, they're sort of like electrical wires that transmit electrical signals, either sending a signal from the nerve to the muscle to contract the muscle, or a signal from the skin or surface of the body to send some sensory information to the brain. And so in this analogy, the wire is what we call the axon of the nerve, and then the insulation around the axon is the myelin sheath. And so peripheral neuropathy can either affect the axon or the myelin sheath or both. And when it affects the myelin, we call it a demyelinating neuropathy. And so in this example here, you can see that there's sort of loss of some of these portions of myelin. And when this happens, it leads to slowing of the transmission of the electrical signals that we can pick up on an EMG test. And then if the problem is in the axon, we call it axonal neuropathy. And generally with length-dependent neuropathies, the problem starts at the end of the axon and then slowly sort of works its way back towards the cell body. And in this case, the speed of transmission is unchanged because the myelin is unaffected, but the actual size of the electrical signal when you stimulate a nerve starts to go down. So when we think about inherited neuropathies, I apologize, but historically this has been kind of a mess in terms of how these are named and discussed. And so I know it can be confusing for patients, and it's also confusing for the clinicians. And so sensory and motor neuropathy, so an inherited neuropathy that affects sensation and motor function, is classically called Charcot-Marie Tooth disease. And this is named after the three physicians on the right that initially described it. And it's broken up into two main categories, although there's types 3 and 4, but mainly we think of type 1 CMT, which is demyelinating neuropathy, so slowing of nerve impulses, versus axonal neuropathy. Just to complicate things, there's also forms of inherited neuropathy that only affect sensation or only affect motor function. And so if it's only sensation, we call it HSAN, hereditary sensory and autonomic neuropathy. And then motor varieties are called HMN, hereditary motor neuropathy. And so there's lots of different causes of these various types, and there's often a lot of overlap. So an HMN can sometimes look like a CMT depending on the patient or the family. And so there's a lot of genetic overlap and what we call phenotypic overlap. So again, it's kind of messy. But in general, those of us that see a lot of inherited neuropathy kind of lump all of these different things into a large umbrella term of CMT. And the other feature of CMT is that it really refers to genetic forms of neuropathy that only cause problems with nerves, but don't cause problems in other organs of the body. But there are inherited forms of neuropathy that do cause problems elsewhere. And so I listed just a couple here. One of them that I'll be talking about later is familial amyloid polyneuropathy, or hereditary amyloidosis. And this can be a sort of aggressive and severe neuropathy that can also affect the heart and can affect the eyes as well. So that's not classified as CMT, even though it's an inherited neuropathy. So when we're thinking about whether someone might have an inherited neuropathy, there's certain sort of signs and symptoms that we look for. So while any sort of sensory neuropathy can have numbness or tingling or pain, usually inherited neuropathies tend to cause more of loss of sensation rather than these extra uncomfortable sensations, although certainly exceptions to that rule happen quite a bit. Weakness in the feet, toes, and ankles is very common. And then one clue can be changes in the way the feet look. So we often, as clinicians, will look for what we call high arches or hammer toes, this curling of the toes, and this can be a suggestion of an inherited neuropathy, although this on its own does not clinch the diagnosis. Because of the loss of muscle bulk in the legs, particularly below the knees, people can develop very thin legs, like is shown in this picture. And then the weakness, particularly below the knees and below the ankles, can lead to difficulties with running, jumping, and balance. And then later in life, as the disease progresses, then you can get weakness and atrophy of the hands as well. And so one of the big clues to inherited neuropathy certainly is if other people in the family have a neuropathy as well. So there's a lot of different ways that neuropathies can move through families and be inherited, and so you'll hear more about that in the second part of the webinar. So when we're thinking about whether someone is likely to have an inherited neuropathy or a different cause of their symptoms, these are the sort of things that we think through. So things in favor of an inherited neuropathy, if there's other people in the family that have it. So certainly parents, siblings, children are the most suggestive. Some neuropathies can occur spontaneously, so a lack of family history doesn't rule it out, and there's also recessive forms that are harder to track through families. Age of onset is another big indicator. So generally with CMT and other inherited neuropathies, while the symptoms might not be obvious early in life, usually we can find some hint that they're there, even in childhood or the teens or 20s. So we call anything that sort of happens after the age of 40 as late onset, and before age 40 is early onset. And most forms of CMT are early onset, although the more we learn these days with the era of genetic testing being so easy, the more we see sort of exceptions to these rules. Another clue is that there can be often long-standing foot deformities. So those curled toes, high arches can often be noted to occur really early in life. And then we often hear these sort of subtle suggestions with difficulties with athletics as a child. So maybe someone will say that they never could really run and keep up with their peers. They may have been last picked for sports activities, or were very clumsy, or just didn't like sports in general because they had a hard time with them. So those can be sort of subtle things to suggest that the neuropathy has been there a long time. So on the exam, we look for the things I sort of outlined in the previous slide. So atrophy of the muscles below the knees, particularly the sensory loss, and sometimes with CMT or other inherited neuropathies, we may find more problems on the sensory exam than the person is actually aware of. And then we look for the foot changes as well. And then on the EMG test, sometimes this can be really helpful in pointing towards an inherited neuropathy, and sometimes not so much. But one of the things that can be really useful, particularly with demyelinating neuropathies, is what we call uniform slowing of nerve impulses. So what this means is that when we find slowing of the speed of conduction through these nerves, if it looks sort of the same in every nerve we test, that we call that uniform. And that usually suggests that there's kind of a problem everywhere in all of the nerves, which is more consistent with an inherited process. On the other hand, things that sort of push us away from thinking about an inherited neuropathy, certainly if the symptoms are sort of rapid in onset, or you can kind of point to a time when they began, that suggests more something that was acquired in life rather than inherited. And then if there's a known other reason, like a diabetic neuropathy that can explain the neuropathy, then that certainly pushes away from an inherited diagnosis. If there's a lot of asymmetry, again, this is pretty unusual for genetic neuropathies. And then if we're able to find some other alternative cause, like major problems with the back or the spine, that can explain the symptoms, then that clearly leads us away from an inherited neuropathy diagnosis. And then the other thing is, if sort of the opposite of what I mentioned with the discussion of what we see on EMG with inherited neuropathy, if we see sort of patchiness, so there's some slowing of nerves on one side and not the other, or different nerves that have different speeds, that is more suggestive of something that was picked up in life rather than genetic. As far as axonal neuropathies, there's not a lot of things that can be found on EMG that really push in that direction, with the exception of maybe sometimes the numbers from the EMG nerve conduction will look sort of more severe than what we find on exam, and sometimes that can be a sign of an inherited neuropathy as well. So to make a diagnosis of inherited neuropathy is sort of the constellation of things I mentioned, but then genetic testing is really at the core of really making a definitive diagnosis. And so you'll hear more about how that works and the various kinds of results you can get with genetic testing in the next part. So this class of diseases called CMT is really large. So far, there's over 100 different genes that have been identified to cause CMT. And so in this picture on the right, this is only a partial list. Within CMT, though, about half of all cases are CMT1A. And that's sort of what I was describing with the uniform slowing that we see in nerve conduction studies. But then there's many, many other forms. CMT2A and CMT1X make up about 5 to 10% each. And then there's, nearly 100 that make up the rest of all of CMT. So for the most part, we can't really tell the difference between different types of CMT just based on an exam. So they look more similar than they look different. So CMT1A looks a lot like CMT2A, which looks a lot like CMT2D. There are some exceptions to that. There are some sort of unique features of some types of inherited neuropathy, but for the most part, they are pretty much indistinguishable when we do a clinical exam. So let's say you have a suspicion for an inherited neuropathy and you do the genetic testing and it doesn't find a genetic diagnosis. So what does that mean? So it makes it less likely that there's an inherited neuropathy, but it doesn't rule it out. And the reason is because while we know 100 different genes now, there's who knows how many that we haven't yet identified. And so we can't say definitively that you don't have an inherited neuropathy because we can't test every gene because we don't know them yet. And just as a sort of point to make on this, we're still finding new neuropathy genes all the time. And this was just last year, a paper that came out describing this new kind of neuropathy, what they call SORD neuropathy. And the reason I point this out is it turns out it's probably the most common form of recessive axonal CMT. And so it's pretty common, but it escaped our notice for a long time for some complicated reasons. But just to point out, there's still a lot of genes that we haven't discovered yet. So why is it useful to get a diagnosis? So what we would like, would be ideal is if that led to a treatment. So unfortunately with CMT, we don't have any treatments yet. It's a very active area of research, my own research and many others, but we don't have any at this point. But there are treatments for other forms of neuropathy. So I mentioned earlier this familial amyloid polyneuropathy, and so a few years ago now, these two really landmark papers described two different but sort of related treatments for this really aggressive form of neuropathy. And so this was really huge in the field and really demonstrated for the first time that we can treat inherited neuropathy. And so this is the kind of breakthrough that we're trying to now move towards in CMT and other forms of inherited neuropathy. But even if there is no treatment, there's things that can be done following the diagnosis. So you can participate in various research efforts to try to help all of us in the community that work on these diseases to help move things forward and work towards treatments. It also helps with prognosis. So when you get a diagnosis of CMT or another inherited neuropathy, you kind of know what you're dealing with. And in general, that means very slow progression over years. And in general, CMTs and other inherited neuropathies, for the most part, don't sort of ramp up and speed up. They sort of go at a slow, steady pace throughout life. It can also hopefully spare you from treatments that might not be needed or might actually be harmful. So some other kinds of neuropathies that are not inherited can respond to things that sort of influence the immune system, and that can be great, but they also have side effects. And so it's helpful to reduce your exposure to those kind of treatments if they're not going to be helpful, and they aren't helpful in CMT in general. And then hopefully it can give you some peace of mind just to kind of have some sense of what you have, and it can help limit further diagnostic workup. And then as we hear about more, this can help with sort of testing of other family members and family planning as well. So let's say you get a diagnosis of an inherited neuropathy. So what happens next? So like any form of neuropathy, we sort of manage the symptoms primarily. So that can be physical therapy, orthotics, ankle-foot orthoses is shown here if foot drop is a problem. And then if pain is a major component, we treat that pain with medications as we would any other neuropathy. Then the other things you can do is connect with patient advocacy groups. There are many of them out there, and you can get involved with those and any to any level you would like. Test other family members to help them in their diagnosis. And then there's also the participation, possibility to participate in clinical research. And so I work with the Inherited Neuropathy Consortium, which is a worldwide effort to understand more about inherited neuropathy. And right now, there are not a lot of clinical trials going on, but for the most part, what we're doing are what's called natural history studies. And these don't really sound the most exciting to get involved with as a patient, but what they really do is help to define how diseases change over time. Because you can't really know if you have an effective treatment, you can't really know that it's working unless you know what happens if you don't do the treatment. So these are really important kind of first steps towards moving towards clinical trials for various forms of inherited neuropathy. So I wanted to highlight a few examples of how the research on inherited neuropathies is moving towards clinical trials, and at the end kind of give you an example of how maybe some of the work on inherited neuropathy can eventually feed back into non-inherited neuropathy understanding. So first, CMT1A, as I mentioned earlier, this accounts for about half of all CMT. And this form of CMT is caused actually by an extra copy, a duplication of a gene called PMP22. And what researchers have done is basically put this genetic change into mice and then study whether they can be treated. And what they've done is sort of an approach similar to what was done with those earlier papers I mentioned on familial amyloid polyneuropathy. So they use what's called antisense oligonucleotides to try to reduce this amount of the PMP22 gene. And what they found was that on the left here is sort of what normal nerves look like in a cross section. In the middle is what nerves look like in these mice that have been given CMT1A essentially. And on the right is what they look like after they've been given this drug to reduce the genetic dose of this gene. And so this was really effective, and this is something that we're actively trying to bring to patients as well. CMT1X is another really common form of CMT, about 10% or so. And this is actually due to a loss of a gene called GJB1. And so in this case, what people have done in mice is use genetic replacement strategies, gene therapy strategies to give back the normal gene since it's lost in this condition. And so what you see here on the lower right is the sort of diseased nerves in these mice. And then after treatment, the nerves look much healthier. And so again, this is something that with time could hopefully be translated to people as well. CMT2A is the most common form of type 2 CMT. And this has been a really active research effort for many years now, and through work in multiple different labs, we've come to understand a lot about this condition. And what's interesting is this is a mutation in this gene called mitofusin-2 or MFN2, and there's actually a very similar gene called MFN1. And what people have found now is that they've developed drugs that can sort of boost the activity of MFN1, and that can sort of compensate for the mutations in MFN2. And so this has been done in mice as well. So in the middle panel, you see sort of the sick CMT2A mice where their nerves are degenerating. And on the right, this is after the mice have been given this drug to sort of boost the levels of the activity of MFN1, and the nerves look much healthier. And so this, again, is something that we hope to bring to patients eventually. CMT2D is a form of CMT. It's caused by mutations in this gene called GARS or GARS. And it's very similar to many other types of CMT. So the idea is that what sort of insights we make in CMT2D might really translate to other forms of CMT. And there are a couple of papers in the journal Science that just came out a few weeks ago. So it's a really prominent journal with exciting findings. And what they basically found, they sort of honed in on what happens downstream of these mutations. And they were able to use, again, gene therapy to sort of fix this defect. And what they found was that this is a graph of grip strength in the mice, so sort of a test of strength. With the CMT2D mice are in the green bar, and if they give them this gene therapy in purple, they look just like the normal mice. And so this, again, is a really exciting finding. In my lab, we study this gene TRPV4, which causes CMT2C and other forms of inherited neuropathy. And what we found is that there's already known to be really good drugs that can block this gene. It codes for an ion channel. And if we give these blockers to either flies, in this case, or mice, we can rescue the degeneration that happens in this in these animal models, suggesting that these kind of drugs might be beneficial for patients that have these mutations. And then the last example I wanted to go through is what I mentioned before, this recent discovery of this condition called SORD neuropathy. And so this has been a really exciting finding. And it turns out that this form of neuropathy is caused by a mutation in an enzyme that's in a sugar metabolism pathway. And what happens because of loss of this particular enzyme, you get an accumulation of this sugar called sorbitol within nerves, and the sorbitol is toxic to the nerves. And what's interesting is that it was already known that sorbitol is toxic to nerves because this is something that accumulates in diabetic neuropathy. And so people have already been focused on developing drugs to block sorbitol production for diabetic neuropathy. And now we have another situation where sorbitol seems to be causing nerve dysfunction. So this is exciting on multiple levels. There's, we think, a large number of people that have inherited neuropathy that hopefully can be treated with this kind of approach. But it also shows us that there's sort of overlaps between inherited neuropathies and other neuropathies like diabetic neuropathies. And it gives us hope that as we study these sort of inherited conditions, the ultimate goal really, is not just to treat the patients that have these genetic changes, but also learn enough about peripheral nerves and peripheral neuropathy that we can come up with treatments that other people can benefit from. So that's all I have for now. And so now I will turn things over to Christy to take you through some more about the genetics.
Oh, thank you. There we go.
Sorry. That was the picture of the fly model they generated that showing that these drugs work within an animal model. Sorry. Now I'm done.
Perfect. Thank you. That was fascinating and great introduction. Now we'll turn it over to Christy Smith, who will give her perspective on genetic counseling and testing.
Thank you. Thank you for having me here today. I'll go ahead and just jump right in. If I can. It's not progressing my slides. Oh, there we go. Okay, there's a delay. All right, so as Dr. McCray had mentioned, there's many different types of hereditary neuropathies, which I won't spend a lot of time going over today, but just to kind of reiterate, the most common cause is Charcot-Marie-Tooth disease, which is also called hereditary motor and sensory neuropathy. And we also know that there's other forms of neuropathies as well that fall into either just motor neuropathies versus sensory. There can also be episodic forms such as HNPP, which is the hereditary neuropathy with liability to pressure palsies, where there's episodic attacks of the neuropathies that are seen. And then as Dr. McCray had mentioned, there's also these complex forms as well, where you can see neuropathy plus other symptoms that can affect other organ systems. And these are more commonly disorders that we might see, say, in our general genetics clinic. And also, as Dr. McCray had mentioned, there are certainly many challenges to diagnosing hereditary neuropathies. First, we know that there's many genes that cause these conditions. There's hundreds of genes associated with these hereditary neuropathies. Sometimes we can, the diagnosis is fairly straightforward, but oftentimes we're doing larger gene panels or much larger genetic testing to identify an underlying genetic cause. And we also know that many of the symptoms are nonspecific and can overlap with each other. We know that even within the same family, with the same genetic condition, even with Charcot-Marie-Tooth disease, that there can be a range of symptoms where some people are affected pretty mildly versus others are affected more severely. And we don't totally understand that, but we know that there's many genetic and non-genetic factors that can influence that. And again, as Dr. McCray had mentioned, there's often no family history that indicates the inheritance pattern. With Charcot-Marie-Tooth disease types 1 and 2, and I'll talk about inheritance in a minute, typically those are autosomal dominant disorders where we might expect to see a family history, but not always if the condition occurred for the first time in that individual and was not necessarily inherited, but could still be passed on. But with other forms, with recessive disorders, parents may be carriers and there's no known family history. and we may see a person who's the first one in the family to have the symptoms with the disease. And also, as Dr. McCray had mentioned as well, we know that there's limitations to non-genetic tests as well, that the nerve conduction studies, the EMGs, and the nerve biopsies aren't perfect. They're just one piece of the puzzle to try to come up with a diagnosis. So in terms of the importance of a genetic diagnosis, certainly the main reason is to identify a cause to help identify prognosis moving forward. Many patients have gone through a diagnostic odyssey to try to figure out what's going on. Medical management can certainly be modified as well, as Dr. McCray had mentioned, that once a diagnosis is made for many of these disorders, there's supportive therapies, but newer gene-specific gene therapies that are going on, and also helping to rule out non-genetic causes, because we know that there's other conditions as well that can mimic hereditary neuropathy, such as having Lyme's disease, diabetes, vitamin B12 deficiency, and CIDP, which is more of an autoimmune disorder that's treated very differently. And we also know, as I had mentioned as well, and Dr. McCray had mentioned, there's gene-specific therapeutics that have been on the horizon. With these RNA interference studies, specifically for the TTR-associated amyloidosis, TTR is the gene that's the cause of this condition. We know that there's enzyme replacement therapies and oral chaperone therapies for conditions such as Fabry disease, which is more of a multisystemic disorder, but can also cause neuropathy. And also, as Dr. McCray had mentioned, some of the clinical trials that are ongoing for PMP22, which is associated with Charcot-Marie-Tooth disease type 1A. And sort of where I kind of come in is maybe the first point, but certainly the last 3 points here as a genetic counselor. So helping to identify, once we do make a diagnosis, identifying at-risk relatives, so other people in the family that are at risk to have the same condition, what the recurrence risk is. So especially for younger people that are of reproductive age, what's the risk of having another child with this condition? And then also what are the reproductive options, which I'll talk about in a little bit more detail later, but this can include prenatal screening and also therapies such as pre-implantation genetic testing that's used in conjunction with in vitro fertilization, which is essentially screening embryos. And then also psychosocial benefits as well. Again, many of these families may have gone through a diagnostic odyssey of many years of not having a diagnosis, and finally having an answer can really be, a really important thing for families. Oftentimes we're finding that they're wanting to have a positive result versus a negative result to have more clarity. So what I do as a genetic counselor is working in conjunction with the doctor. So I'm not performing physical exams or EMGs or anything like that, but reviewing their medical history, how that patient was thought to have that diagnosis of a hereditary neuropathy, and then also collecting family history information. So not many doctors take a full family history. I think Dr. McCray and others are pretty good at doing that, but most times when you go to your physician, they're not asking more detailed questions about extended family members. So what I'm creating is similar here to a pedigree down at the bottom. So circles are females and squares are males. So drawing out a patient's siblings, parents, grandparents, aunts, uncles, cousins, at least going out at least 3 generations. And by drawing a pedigree, even if there's no one else that's affected in the family, it does help to identify the possible inheritance pattern and then identifying who else in the family could be at risk. And this also helps to figure out what's the most appropriate test to order, which I'll talk a little bit more later, but whether we're thinking of doing targeted testing for a specific gene variant that we know exists in the family and is the genetic cause, whether we're considering a gene panel where we're looking at multiple genes associated with hereditary neuropathies, or even whole exome sequencing where we're looking at all 20,000 of our genes. And it's also important too that if any genetic testing has been done in the family, to try to obtain a copy of those genetic test results, because those are important, that instead of doing this much larger testing, we would only test for that specific variant in the family, assuming that that's the cause for the neuropathy. And then again, as I had mentioned, thinking about the reproductive risks and options and risks to other family members. So to take a step back, some of these terms are, I'm sure, a little bit foreign and jargony. So when we think about genes, genes are the instructions that tell our body what to do. We all have the same genes, it's just the spelling of the genes are different. And we all have about 20,000 genes in our body. And for most of our genes, we have 2 copies. So we inherit 1 copy from our mother and the other copy from our father. And so genes are located on chromosomes, and chromosomes are packaged within cells of our body that have a nucleus, except for our red blood cells that don't have a nucleus. And we all have 46 chromosomes or 23 pairs. So our genes are scattered along our chromosomes. And again, genes are the instructions that tell our body what to do. So they're made up of a series of letters, A's, C's, G's, and T's that code for proteins. So kind of the way that I always say to patients to kind of think about this is when we're doing genetic testing, if we're looking at, say, 30, 100 genes, we're reading through 30 or 100 books to try to find a misspelling, a missing or extra page within that book, a missing paragraph, a missing chapter, something that makes that book unreadable or makes that gene not work properly. So really, it's almost like trying to find a needle in a haystack. And then once we can find that needle in a haystack, then the testing is much more targeted and directed for other family members. So when we refer to a mutation or a variant or a pathogenic variant or a disease-causing variant, it's essentially a change in the coding of the DNA within that gene. So in terms of inheritance patterns, these are the different inheritance patterns that we think about for families. So with autosomal dominant disorders, kind of going back to, we all have 2 copies of most of our genes within our body. We inherit 1 from our mother, the other from our father. So having a dominant disorder is where having 1 non-working copy of the gene is sufficient to cause the disease. And that really describes most forms of hereditary neuropathy that we think about. So whoever has a dominant disorder, there's a 50% chance to pass it on to the next generation. So you either pass it on or you don't. If you pass it on, the next generation is at risk and could also pass it on. If you don't pass it on, it stops there. Certainly one misconception is that these disorders, genetic conditions, can skip generations, and they don't skip generations with dominant disorders. It can just be more confusing that there's certainly a lot of variability in the symptoms that can develop and the age at which someone develops symptoms. So it may seem like it's skipping a generation, but it is being passed on. And then with autosomal recessive disorders, that refers to, again, going back to, we have 2 copies of each gene, so both copies of the gene are not working. So you inherit 1 non-working copy from your mother and the other from your father. And each parent is usually a carrier for a working and a non-working copy, so then they don't have symptoms of the disease. But when each parent passes that on and a child inherits 2 non-working copies, then they have that condition. So typically with autosomal recessive disorders, we don't see a family history of that condition. And if we do see a family history, it would likely be in siblings of the same generation. And so typically there would be a 25% risk of having another child with that same recessive disorder. And you can kind of see down here that I have shown a pedigree, and you can see very subtly that there's 2 lines drawn in between these 2 individuals. And this denotes consanguinity, which is also referred to as just shared relatedness. So we know that if 2 people have a distant cousin or are related to one another, they're more likely to share more genetic traits in common, and so therefore more likely to have a child with a recessive disorder. So these dots in the middle here signify that both parents are carriers, and then these people colored in would be affected, and the people not colored in would be unaffected. And if they had another child, there would be a 25% risk to have another affected child. With X-linked disorders, that has to do with the X chromosome. So as I had mentioned, we all have 46 chromosomes, 23 pairs. They're numbered 1 through 22. The last set of chromosomes is our sex chromosomes. So women have 2 X chromosomes, men have an X and a Y. And we know that there's genes on the X chromosome that can cause hereditary neuropathies. They're less common, but in people that have those, typically males are more likely to be affected, and females either can not be affected at all or maybe more mildly affected. And it may look autosomal dominant in families because you can see it being passed on from one generation to the next. But one feature of X-linked inheritance is that there's no male-to-male transmission because all men pass on their Y chromosome to their sons and their X chromosome to their daughters. And so as I had mentioned, males and females can be affected differently with X-linked disorders. And then there's also mitochondrial inheritance, which is also a less common cause of hereditary neuropathies, but the mitochondria are a separate portion of the cell. And so you have within the nucleus of the cell, the chromosomes with your genes and your DNA. Outside of the nucleus of the cell, you have what's called the mitochondria. And the mitochondria are responsible for energy production, and not just I feel awake or tired, but fueling the energy for all of the major organ systems, including your eyes, your ability to hear, your brain, your heart, your liver, your kidneys. And so often with mitochondrial disorders, we would expect to see multiple organ systems affected, including the central nervous system, where you can see neuropathy. Sometimes neuropathy is the only organ system that we see affected. Sometimes there's others as well. But essentially with mitochondrial disorders, they can either be caused by genes within the nucleus, or the mitochondria have their own set of instructions, 37 genes. So there's a separate test that we can look at the mitochondrial genome. And the mitochondria are only inherited from your mother. So typically in families where we suspect a mitochondrial disorder, we'd look for the mother side of the family. And there can also be variability throughout the generations if and when people are affected for more complicated reasons that I won't go into today. And then of course there's multifactorial inheritance, where there's multiple genetic and environmental factors that we're still kind of learning about at this point. So there's many different types of genetic tests. They're not all created equal. Certainly we can do genetic testing through a blood sample or a saliva sample, but again, there's different ways that we actually perform the test. So as I had mentioned earlier, there's targeted testing where there's a known variant within the family. So we find a misspelling within that book or that gene that makes that book unreadable or that gene not work. And so with that specific misspelling, we would target that in other family members. So we might say, in book A, page 576, paragraph 3, word 5, there's a letter A that got changed to a G. So let's look for that specific misspelling in other family members. And again, it's helpful to have a genetic test report for someone that's tested positive. And then there's larger gene panels that cover many hereditary neuropathy genes. And so oftentimes, this is what we're doing when someone has a diagnosis, so they are affected, they have symptoms, and we're trying to figure out a molecular diagnosis by doing genetic testing, where sometimes it can be straightforward, where we might suspect CMT1A, but oftentimes we're doing these much larger panels just because of that overlap of symptoms. As Dr. McCray had mentioned earlier, so negative genetic test results do not entirely rule out a hereditary neuropathy. It makes it less likely, but we don't know everything in genetics. So of the 20,000 genes that we all have, we understand the function of about 5,000 of our genes in relation to human disease. So that means that the other 15,000 of our genes, they're there, they exist, but we don't know what they do, and we haven't connected the dots between those genes and human disease. So we're constantly learning about these new disease genes that a genetic test today could be completely different in the future as we learn more genes that are being added to these panels, as Dr. McCray had talked about, and some of these newer genes that are being discovered. And then we also know that there can sometimes be an overlap between hereditary neuropathies and other musculoskeletal disorders. So certainly this is, I leave up to the neurologist, but just kind of keeping in mind that, if we get a negative genetic test result, are we ordering the right test? So that's something else to think about. And as I mentioned with mitochondrial disorders, so we can do a blood test, a buccal test, which is basically just a cheek swab or saliva, versus a muscle biopsy. And this is essentially because when we're truly looking at the mitochondrial genome, these 37 genes, we can certainly look at a blood or a saliva sample to identify a genetic cause, but sometimes it's not there. And the reason for that is because all of the genes that we have in our body, if we identify an inherited mutation, it exists in all of the cells of our body. It's something that we're born with. It doesn't change over time. With the mitochondria, it's a little bit differently, that different cells within our body can have more or less mitochondria that are affected. And oftentimes we see more mitochondria affected in organ systems that we see symptoms. So for example, if someone has a muscle disease or a nerve disease, they might have more of their mitochondria that are affected there, versus if we look at their blood that's not affected, we may not see the gene alteration there. So certainly thinking about the sample that we're using also matters. So we may use a biopsy sample from that specific tissue if we don't make a diagnosis through blood or saliva. And then with whole exome sequencing, which I'll talk a little bit more. So again, as I had mentioned, we all have about 20,000 genes, and genes only make up about 1 to 2% of all of our DNA. So the rest of our DNA, the 98, 99% of our DNA, we know that it's there and it exists, but we're still trying to understand what the rest of our DNA does. There's another test called whole genome sequencing that is used to look at all of our genetic information. But again, even though we have the technology, we're still learning in genetics, so we still don't know everything. The testing is definitely getting better, but our knowledge, we're still trying to catch up. So again, as I mentioned, when we're doing whole exome sequencing, a negative result is negative today. It's not negative forever, because we only understand what about 5,000 of our genes do. So oftentimes when we're doing whole exome sequencing, we have the option in the future to do what's called a reanalysis. So a year, 2 years from now, we can ask the laboratory to look at the data again to see if there's a new gene that we've learned about that the lab didn't know to look for before. So we're never really closing the book whenever we get a negative genetic test result, unless a non-genetic diagnosis is made. And then in terms of the importance of trios, what this means is that when we're doing whole exome sequencing, it really is like trying to find a needle in a haystack. So it's most helpful to interpret the test result if we can include samples from both parents, so mother and father. Certainly that's not always possible for various reasons. Sometimes we may choose to include other family members in the testing, but standardly including both parents is helpful because knowing the inheritance pattern helps the laboratory to better further funnel down the testing. And with whole exome sequencing, I should mention that even though we're looking at all 20,000 genes, we're only looking at those genes that matter in terms of the diagnosis. So whole exome is not looking for all health problems. It's looking at someone's medical history, so neuropathy, and then funneling the testing down to look at only neuropathy genes to make that diagnosis. And then secondary findings refers to information that is sort of secondary information that we can find on exome, and it's usually optional. So you can either choose to know this information or not. And this is a list of over 70 genes the American College of Medical Genetics has put together that are medically actionable. So whenever you're undergoing exome, you have the option of knowing if you have, say, an alteration in a gene that predisposes you to breast cancer or colon cancer. And the thought behind this list of secondary findings is that these are all treatable disorders. So there's something that we can do different about the outcome. So usually conditions that are not treatable, like Parkinson's disease or Alzheimer's dementia, or Huntington's disease, would not be included on this list. And again, you have the option of knowing or not knowing this information. And whole exome is not perfect, so it can't detect all genetic disorders. So there's certain repeat expansion disorders. I know Dr. McCray had mentioned this canvas disorder. So repeat expansion just means that there's a series of letters, A's, C's, G's, and T's that are repeated over and over within the gene. So if there's a repeat of certain letters, this test is not able to find that. A good analogy is that, if we're reading through a book and the word "the" is copied over and over again on one page of the book, the whole exome sequencing is not going to catch that because it's doing a spell check or looking for missing or extra material. It's not looking to see if there's certain letters that are or words that are repeated over and over. Exome can't look for non-coding variants. So what this means, a good analogy is that if you're reading through a book to try to find a misspelling, if there's a misspelling in a word in the margins of the book, exome cannot detect it. So that's something that's typically identified on a genome. And there are certain deletions and duplications within genes that exome can't capture. So again, genetic testing isn't perfect. And just to kind of touch briefly on the reproductive risk that we could identify. So essentially, if we make a genetic diagnosis, we know that this, for people that are of reproductive age, that they can use this information to make different decisions either prior to or during a pregnancy. So during a pregnancy, prenatal diagnosis is done by either a CBS or an amniocentesis that can be done at different gestational ages. These are diagnostic procedures. And then we also know that prior to a pregnancy, that couples of reproductive age can go through fertility centers and go through the process of in vitro fertilization, and then take the extra step of testing embryos for that specific gene that's causing that disorder. So if it's CMT type 1A, we could look for the PMP22 duplication within the embryos and then put back the embryos that don't have that duplication. So then you're guaranteeing that you're not passing on this condition to the next generation. Of course, there's options for adoption, embryo adoption, egg or sperm donor donation. And typically this is discussed by a prenatal genetic counselor. I'm not a prenatal counselor, so I would probably refer these patients to one of my colleagues at Hopkins. And then just a couple of points about, what I do as a genetic counselor. Certainly I think it's easy to order a genetic test, but interpreting it can be difficult. Certainly with a positive result, it may be straightforward in terms of explaining that diagnosis, or negative. We don't have an answer, but again, genetic testing isn't perfect and we don't know all of the genes that cause genetic disorders. But we can also find uncertain test results. So that means we find a misspelling within a gene, but we're just not sure if that misspelling disrupts the function of that gene and causes that genetic disorder. So it's not always black and white, positive or negative. Sometimes we're getting these uncertain test results that we just don't know. And it can be helpful in those scenarios to test other family members to see how it's being inherited in the family, especially if there's other affected individuals, seeing if that variant segregates with the disease. And it's also really important too that for the condition that we're thinking about, that anyone that we're testing in the family has a neurological exam by a trained neuromuscular specialist, such as Dr. McCray, to help identify, do they have the condition that's associated with the gene variant that we're testing them for. And then of course there's psychosocial effects. So I'm a trained counselor, and so talking to these families not only about their test results or how it has implications to other family members and genetics education, but talking through how are they coping with this, diagnosed or even an undiagnosed disease, which can be very challenging. Or once you receive a diagnosis, how are you making sense of that within the context of your own life? Talking to other family members, thinking about these reproductive options, treatments, finding support groups. And I think there can be other issues as well, such as, guilt as to thinking about that people passed it on to the next generation. So talking about, what that means. We all pass on lots of things to our kids, lots of good things too. So kind of putting it in context. And also just thinking about what are the relationships with other family members. Everybody has different relationships within their family, people that they talk to, don't talk to. Some people are adopted. Some people just don't know certain sides of their families. So that can certainly be challenging as well, especially if we receive an uncertain test result and there's just information about the family history that we just can't uncover. And just some basic information, as I had mentioned, so genetic testing can be done on blood, saliva, buccal, which is a cheek swab, or biopsy tissue. Now in times of COVID, certainly doing a lot of telemedicine, so sending kits to people's homes where they can just fit into a tube, send it back to the lab via FedEx, so it's usually pretty quick. Genetic test results, it really depends. Sometimes they can take anywhere from a few weeks to a few months. Usually whole exome sequencing takes longer versus, targeted testing, looking at a specific variant. We can often get that information back pretty quickly. And all of the genetic testing that I'm doing is clinical testing that's done in a laboratory that has CLIA certification. And also is subject to like HIPAA rules and regulations, so protecting your information, that it's not being sold to outside companies or things like that. 23andMe is very different from the clinical genetic testing that I do. So 23andMe is direct to consumer. So there's typically not a physician that's ordering it. Typically, this is more for fun information, although there is more medical information that's being included on 23andMe. I'll just say that I'm a little bit hesitant to use those companies because they are selling data, and it's not always, you're not always getting the whole picture. So I think it can be fun to do 23andMe or Ancestry.com, but certainly doesn't substitute for good medical care. And just wanted to mention very briefly about GINA. This is the Genetic Information Non-Discrimination Act, which typically applies to unaffected individuals. So this would be for family members of someone that has a hereditary neuropathy with a genetic cause. So anyone else in the family that could be at risk. What this law says is that it protects against discrimination from your health insurance and your employer based on a genetic test result, but doesn't protect against potential discrimination with life insurance, disability insurance, and long-term care insurance. So oftentimes I tell patients that if you're unaffected and you're doing testing that is more pre-symptomatic testing to see could you develop symptoms in the future, to go ahead and take out some of these other policies, because it's not like these plans can drop you. It's more just if you're taking out a new policy or additional coverage, that these insurance plans could ask you if you have genetic test results and can underwrite based on that information. And I don't want to take up too much more time. I only have 2 slides here. I want to save some time for questions, but just a plug really quickly that genetic counseling can certainly be helpful regardless of whether or not you've had a positive, negative, or an inconclusive genetic test. Just kind of thinking about new testing options if you've had negative testing in the past, kind of understanding the implications of a result, positive or inconclusive. Variant interpretation for inconclusive test results. This is certainly very complicated, and I think about this all the time. Updates to genetic test results, because we know that that can change all the time. And then just thinking about who's ideal in the family to have genetic testing. So typically we're doing genetic testing, this needle in a haystack testing on someone who's affected, and then testing unaffected relatives once we identify that gene alteration. And also having a neurological exam is very important too, just to assist with the genetic test results. Typically, you can find a genetic counselor through like your primary care doctor. You can ask for a referral, but you can also go to nsgc.org, which is our professional organization, and you can find a genetic counselor there in your area by entering your zip code. So I will stop there. Thank you. Can't hear you, Nancy. Nancy, yeah, I think you're muted.
All right. Doesn't the organizer always forget how to work the platform? Sorry, everybody. Thank you, Christy. Thank you for all the information. You all have given us such great information. We have some great questions. So we're going to impose a little bit longer on your time, if you don't mind. Anyone in the audience, we'd love to have you stick around for a couple of questions. This will also be recorded and you'll be able to hear it later if you can't stay around. But I want to jump into some really good questions that have come out. I guess I will ask Christy first, but please, Dr. McCray, step in if you have a viewpoint on it. We had a couple of people who have some of the symptoms that you've described. They've had tests years ago about with hereditary or inherited neuropathies, and they were negative. Has the testing gotten better? Should they go be tested now? And what would be their first step? I'll maybe start with Christy, and then Dr. McCray, you can give from the doctor's perspective.
Yeah, definitely. I mean, we're discovering new genes all the time. Even within the last couple of years, I've had people that have had testing just, a few years ago, and the labs have updated their panels and there's more genes that have been discovered. So yeah, I think that there's definitely value in inquiring about additional genetic testing options that are available, and certainly having a copy of your test report to view to see what testing you've had done to make that comparison. And again, you can either go through your doctors, for a referral, or talk to your neurologist who's, kind of aware of a lot of this genetic testing too. I know Dr. McCray does this testing a lot on patients.
Okay, so that was going to be my next question, Dr. McCray. Do they go to you as the neurologist, or how does a patient start?
Yeah, I think you could probably go either direction. I think it's helpful, as Christy mentioned, for the neurologist to kind of settle on a sort of category of genetic diseases that we're thinking of, and that helps us guide. Most of the testing we do is based on panels of related conditions, whether it's inherited neuropathy or myopathy, things like that, have separate panels, and so the neurologist can really help to move things in the right direction. Having a genetics counselor involved is also very helpful. But people that see a lot of inherited neuropathy like me would often order the genetic testing directly. And I totally agree that if you haven't had genetic testing in several years, it's worth sort of updating it. Just since I've been doing this, I've seen the panels, even in the last few years, go from 70 genes to 100 plus genes, and not just super rare, forms of neuropathy, but some that are relatively common. So I think it's worth an update if it hasn't been done in a while.
And is it something, Dr. McCray, that's done standard? If somebody has been diagnosed with small fiber neuropathy or another form of neuropathy, is there any likelihood that it could be hereditary, and should they discuss that with their neurologist as standard practice?
I wouldn't quite say it's standard practice, but there's not a lot of downside to doing it in the right clinical situation. So I personally have a pretty low threshold. So I sort of outline those things that I think about that make inherited neuropathy more or less likely. If I don't have to have all of those to send genetic testing. If I have a few, then it's often worth doing, partly because the cost, the difficulty of doing it has come down so much now that, and I've been surprised by situations where I had a low suspicion and I found a genetic cause. So I wouldn't call it standard of care, but I don't think everyone should have genetic testing, but a lot, I have a very low threshold to send these panels.
Okay, and if a patient has peripheral neuropathy, and I guess I'll separate it, you went through it very clearly, Christy, with people who have hereditary neuropathy, but maybe you can sum it up again, and maybe Dr. McCray for general patients. How likely are they to pass it to their children? If, what someone wants to know is they have 3 sons, are they going to get peripheral neuropathy? What's the likelihood? And maybe, Christy, you can start on either on hereditary neuropathy and the likelihood of those conditions that cause peripheral neuropathy, and then maybe Dr. McCray, you can follow up again on, does a peripheral neuropathy patient have to worry about their kids?
Yeah, I mean, I think the first step is seeing a neurologist and having, all of the appropriate exams and imaging to make sure that we're sort of in the right place. And then we need to do the genetic testing, make sure that we're ordering the right test, and identify that underlying genetic cause. And really, we don't know the inheritance until we have a diagnosis. So once we have a diagnosis based on what we know about that gene, we can say that this gene has an autosomal dominant inheritance, recessive inheritance, X-linked, et cetera. And then we can give more specific information about the risk of passing it on. So whether it's a 50% risk, a 25% risk, that matters what their partner has, X-linked, mitochondrial, et cetera. So it's kind of hard to answer the inheritance question without having a known genetic cause.
Okay, and then on the flip side for that, if in general, peripheral neuropathy, Dr. McCray, should a parent worry about their kids, adult kids or otherwise?
I think if the neuropathy is sort of onset late in life and doesn't have many of the features that suggest that it's an inherited neuropathy, then the likelihood of it I wouldn't say it would be passed on directly, but there may be some sort of risk factors that run in the family that put other family members at a little higher risk than the average person. But in the absence of a strong suggestion of inherited neuropathy, then I wouldn't worry too much about passing that on.
Okay, that's a good answer. That's, I'm sure, a relief for many people. Christy, this is a very interesting question and very general. Do you see more men or women with hereditary neuropathies? Have you, through your practice, do you notice that kind of a gender difference or anything related that strikes you or has struck you?
Not that I've seen. I'm sure Dr. McCray can probably answer from his experience seeing all of these patients, but I'd say the only gender difference is if you're thinking about like an X-linked disorder that, it affects men and women differently, but the majority of these hereditary neuropathies are dominant, and that affects men and women equally, as does recessive inheritance.
Okay, have you seen a difference, Dr. McCray?
I don't think so, no. See an even mix of both inherited neuropathies and non-inherited neuropathies, men and women, pretty equally mixed.
Okay, well, so it really is dependent upon this about having it identified in the test results itself.
Yeah, I should say one really active area of research is trying to understand. Some people may have a diagnosis of idiopathic neuropathy, meaning that they've gone through testing for things either genetic or non-genetic that typically cause neuropathy and came up empty, and so they don't have a clear reason for having neuropathy. Sometimes that's a constellation of lots of things, but we also believe there may be at least it may not be genetic in a pure sense, whereas one gene causes the problem, but it may be a mix of sort of genetic risk factors. And so there's a lot of research to try to identify those genetic risk factors. And what I was sort of hinting at with that sword neuropathy example is we think, maybe there's some overlap between genetic risk factors for idiopathic neuropathy and inherited neuropathy like CMT. And as we sort of study those together, sometimes the lines blur a bit.
Yeah, that was one of the questions. We have a lot of patients with idiopathic neuropathy, and they are curious, should they be tested? Should they not be tested? And I guess maybe to address that issue it's a conversation with their neurologist first. Is that correct?
Yeah, I get a lot of referrals that ask that question, that type of question, where there's some features that suggest that it could be dealing with an inherited neuropathy versus others that suggest maybe it's not. And so each case is different, and it's kind of comes down to taking the whole picture and deciding on how likely or unlikely it is that there could be an inherited process. And then again, if I have a low threshold for doing the genetic testing, because I don't see a huge downside to it these days, at least. Used to be that a lot of these, even the limited genetic testing panels that were available were very expensive, and that's not the case anymore.
Right.
And also, these disorders are common. They're sort of like pan-ethnic, so they're not seen in typically, certain ancestries. As a genetic counselor, I ask about ancestry, what countries are your family from? And we know that there are some places in the world that have a preponderance of certain genetic disorders, just, for different reasons of, populations or having children with people that you're, related to, but there's not specific, there can be, but it's not common that we see. It's usually.
That's helpful. Can a patient have small fiber neuropathy? Can that ever be an inherited neuropathy? And do you see people with more than one type of hereditary neuropathy?
So there are.
I guess I'll ask Dr. McCray first.
Sure. Sorry, I just took that one to myself.
That's okay.
There are some genes that are known to cause pure small fiber neuropathy. So there tend to be ion channel genes that control the sort of electrical transmission through particularly the pain sensitive nerves. And so that is definitely a situation that can be inherited. A lot of times small fiber neuropathy is not, but that type of neuropathy does not exclude it being genetic.
Right. And then I guess to Christy, do you see, is it common or can a patient have more than one kind of inherited neuropathy? Do you see across some sort of cross sector of types of neuropathies?
Yeah, I mean, it's not super common. Typically, we see one type of hereditary neuropathy in the family, but in genetics, we see it all the time that you can have 1, 2, 3, 4 different genetic disorders. I think I've seen a patient with 5 once. So, I mean, we used to think in genetics, there's one genetic disorder that you have, but we know that that's certainly not the case. And certainly in situations where parents are related to each other, share more genetic traits in common, there's definitely a higher chance of having children with more than one genetic disorder. So to answer your question, I'd say it's not common, but maybe more common than what we think.
Okay, and then to close us out, because everyone has been very generous with the time, I'd love each of you to perhaps give us a glimpse into the future, where you see genetic testing and gene treatments as being beneficial for all patients with peripheral neuropathy from your different perspectives and your areas of expertise. I don't know if you want to start, Christy, or Dr. McCray, you would want to start this time, either one.
You can go ahead.
You want to start?
Okay. I guess I would, in the 5 to 10 years, I would picture a couple of things. So one, for people that have genetic neuropathies, I think we'll have a larger set of genes to look for, but I hope we'll be enrolling some specific types of neuropathies into clinical trials, whether they're gene therapy trials or other trials that get at specific mechanisms of the disease of certain kinds of neuropathy. I would love to say that I expect to see a general treatment for all kinds of neuropathy, but I don't think I don't know if that's quite on the horizon, but I think there's going to be sort of what we call precision medicine for CMT, where certain types where we have a good understanding can be treatable. And then I think for non-genetic neuropathy, I think what I hope in the next 5 to 10 years is we'll get more of a sense of results from things that we sort of these large scale tests of genomes and kind of we call lipidomics, metabolomics, and all these omics kinds of tests to really start to understand what are the complex factors that lead to idiopathic neuropathy, so that we can better diagnose it and better understand sort of each person's neuropathy, and then hopefully also that will lead to some ideas of how to treat those different forms of neuropathy. I think idiopathic neuropathy is probably lots of different kinds of neuropathy that we don't understand, and I think we're going to make progress in understanding those over the years.
Terrific. That's terrific. And Christy, from your perspective, where do you see all of this testing and knowledge going?
Yeah, and I think I echo a lot of what Dr. McCray said. I think definitely, our knowledge of genes and the genetic technology is changing all the time. And so, like I said, we only understand 5,000 of our 20,000 genes. There's going to be more gene discoveries. The genetic testing is going to get faster, cheaper, better. That, we can do whole exomes now, but I think, we're starting to do whole genome. Insurance is not always covering it, but I think that it's definitely something of the future. I don't know that we'll do it for everybody, but I think we'll have better diagnostic tools in the future. And definitely in terms of clinical trials, I think, Dr. McCray is at the cutting edge of that. But I think with many other genetic disorders, with doing gene therapies and these ASO therapies, it's kind of set the stage that I think we're definitely moving in that direction of more of the precision, personalized medicine, that there's not really a one size fits all, and doing more targeted treatments based on the underlying genetic cause.
I'll just add one more thing if I can. I think in the past several years, there's been a bit of a shift in the way that pharmaceutical companies think about diseases. And so they've shifted somewhat away from common acquired diseases and moved towards genetic diseases, with the hope, I think, that when you have a genetic disease, you have a really good foothold on what's going on and how you can treat it. And then once you start to establish those strategies and find that they work in the kinds of conditions that Christy was just talking about, then those strategies can be expanded to other conditions. So right now there's a lot of interest in treating these kinds of conditions, which is great for people that have them, and I think it also will yield treatments beyond inherited neuropathy eventually.
Well, that leaves us here and all our patients with a lot of hope, and we appreciate your time. I think we could probably have another session and keep talking about this very interesting topic, but we appreciate your time and your expertise and appreciate everybody joining us today. I want to just make mention that as a follow-up to this presentation, I would like to announce that we will be having a webinar next month that will be at the end of October. It will be based strictly on one condition that manifests itself in peripheral neuropathy, the hATTR amyloidosis. That will also be sponsored by Alnylam, and that'll be on the 26th of October, which happens to be Global Amyloidosis Awareness Day. So that was a lucky break for us. Look for our website or our emails. We will be announcing registration for that soon. And then a final thank you. If you liked what you heard here, please continue to support us. You will get a recording, a seminar, rather a survey after this seminar that we'd love for you to fill out to give us some other ideas. And if there's anything else we can help you with, please contact us. And with that, again, thank you, and hope to see you all at our next webinar. Have a good afternoon.